Committee members, I was going to say, have we started the recording? Yes, we have. Thank you.
Yeah.
We have our committee members present, and we can hear each other. Okay, fabulous. And we have guests. So welcome to all of the guests. We do appreciate it. And there's another student who is in the class with me. All right. So I'm going to stop looking at who's popping in. So Dr. Elliott, if you could please be the one to let people in, if you wouldn't mind. So committee members, we are here and present. Everybody can hear us, correct? What I would like to do is establish the fact that all eyes are on Karish tonight. So please, I would ask that everybody goes on mute. I would also ask, please, that you take off your cameras, because the last thing you need are people looking at you while you are trying to speak. So please, everybody come off of camera, including committee members. What we will do is then ask everyone to leave after she is done presenting, except for the committee members and faculty. And we will have a question answer period, and we will go round robin. I will be the last one to ask questions. The only ones who will ask questions are the committee members. At that time, we will ask Karish to leave. The committee will convene, assess whether she has met the parameters as set out by the University of Phoenix, and call you back into the room. So you'll go out and come back in. We will then approve or not approve, but I don't know if we're going to go down that path. So at the end of the day, this is yours. This is your expertise, and we're here to enjoy your presentation. So good luck to you, and we will talk to you in a bit.
Okay, can everyone see my slide? Okay, so welcome to my oral defense for primary care physicians and patients' experience and perceptions with telemedicine. And as we mentioned earlier, this is a qualitative descriptive case study. Just a brief background for myself. There's over 2 decades of healthcare administration experience, and my career has pretty much included roles from claims examiners, health information educators. I've taught health claims examining and revenue cycle at the vocational level, health information technology at the community college level as well, fostering the next generation of healthcare professionals. So my lived experiences, I wanted to share that really quickly. As a scholar, practitioner, military mom, and healthcare leader, that enriches my academic contributions. And my doctoral research focuses on communication effectiveness in the telemedicine area, bridging the real world administrative insight with, of course, the theoretical exploration to improve patient provider relationship in virtual care. So, what was the problem? The problem is the ineffective communication between primary care physicians in applying telemedicine technologies, resulting in misunderstandings due to technical challenges between patients and physicians. Now, despite the growing integration of telemedicine and primary care practice, communication between patients and physicians during virtual visits has not shown to be equally effective as in-person interactions. Existing studies have largely concentrated on the convenience, the accessibility, and the technological efficiency of telemedicine rather than the quality in the patient-physician communication and its effect on mutual understanding, trust, and diagnostic accuracy. What is not yet fully known is how ineffective communication between patients and primary care physicians manifests when applying telemedicine technologies, particularly when technical challenges lead to misunderstanding, reduced diagnostic clarity, and weakened relational trust. Now, although previous studies acknowledge telemedicine's benefit in improving access and continuity of care, few studies have qualitatively explored or described how communication breakdowns occur during virtual consultations or how these experiences differ from in person visits. This gap limits the ability of healthcare leaders and primary care providers to implement communication strategies that ensure the same level of quality, patient satisfaction, and clinical effectiveness in telemedicine as in traditional office visits. This study demands attention because it addresses the foundational issues at the intersection of clinical care, communication, and technology. How effectively patients and primary care physicians communicate when using telemedicine platforms, particularly in audio only or video based platforms or formats. Now, the purpose was pretty much to describe both patients and physicians' perspectives of effective communication in telemedicine. Healthcare leaders, policymakers, and clinicians must not overlook the relational cost of digital care delivery. While telemedicine offers access and convenience, this study reveals that it also introduces new barriers, diagnostic uncertainties, patient disengagement, and fractured communication that may compromise quality care, particularly when visits are conducted via telephone without those visual cues. Now, the qualitative method was applicable for this study, enabling descriptions of participants' perceptions, their opinions, their feelings, and their beliefs. According to previous researchers, using the qualitative method can support with exploring how primary care physicians make decisions and their motivations to take or avoid specific actions. So the descriptive case study design was selected to complete the study. Researchers often conduct qualitative studies in healthcare because the qualitative approach allows for gathering of that data and provides insight into techniques not previously implemented to influence change in clinical practice and improvements in quality. The descriptive case study also offers an opportunity to describe the phenomenon, which may require more information. I had to really consider the consideration of epistemological or ontological perspectives. And so I chose the social constructivism lens, focusing on how experiences of illness, wellness, and care are shaped by cultural and social interactions. Now, the exploratory or explanatory case designs, both of which can explain what is happening and why, were not chosen for the study. I plan to use those in another case design in the future. However, as the initial study, I wanted to first describe what was happening post-COVID by leveraging the descriptive design, which allows for describing collaboration experienced by primary care physicians and patients who can convey information that is essential for practice recommendation and policy development in healthcare. Now, for this study, the target population consisted of approximately 197 primary care physicians and 1,200 patients across one healthcare organization. I
Good.
used per I used purposive sampling to focus on participants who could provide rich, relevant insights into the research questions. Now, the sample included 15 participants who met specific criteria that ensured they had the necessary experience and the relevance to the study. Eligibility criteria included that the participant must be primary care physician, a patient currently employed in the organization, and had or provided telemedicine services within the past 2 years. And of course, additionally, the participants had to be at least 18 years of age and provide their written consent to participate. Now, the focus was on 5 key research questions. The first research question was, how do patients describe the effectiveness of communication with their primary care physician in telemedicine? Next, what are the patient's experiences regarding the usefulness, ease, and future intentions of using telemedicine services? The next one was the third question, which sought to answer, how does primary care physicians describe the effectiveness of communication with their patients in telemedicine? The fourth question was, what are the physician's experiences regarding the usefulness, ease, and future intention of using telemedicine services? And the last question was pertaining to the medical record documentation about communication challenges the primary care physicians experience during telemedicine visits with their patients. Now, my framework, utilizing the philosophical social constructivism lens, which guided the data collection process, I sought to understand how participants constructed meaning through their telemedicine experiences. Through interactive dialogue and interviews and focus groups, I captured multiple perspectives that reflected the social reality of physician patient communication. The theoretical framework to understand the phenomenon was TAM, Technology Acceptance Model. This model served as my primary theoretical framework, focusing on how perceived usefulness and ease of use influence future adoption. Now, the purpose of the literature review was to examine existing research on telemedicine communication effectiveness between patients and providers, and the theoretical model used to explain the TAM in healthcare. Despite growing research on telemedicine, the literature lacked qualitative studies that examined the specific impacts of communication breakdowns from both the patient and the provider's perspective, particularly using audio only modalities. And very few studies incorporated medical record documentation to triangulate those communication issues. Researchers wanted to know what was the perceptions of users post COVID, and most of the findings were related to technical challenges. However, my study addresses the critical literature and the knowledge gap. And building on these gaps, I summarized key insights from the literature that informed the purpose and the design of the study. Literature on communication and telemedicine revealed several gaps, particularly in the quality of patient provider communication and cultural linguistic barriers. Importantly, few studies have examined how physicians navigate these communication barriers, especially in diverse patient population post-COVID. These gaps directly influenced my research question and supported the significance of my study with the experiences of primary care physicians and patients. Now, data was collected from semi-structured interviews with 10 primary care physicians. Now, 20 volunteered, but only 10 completed the consent forms timely. And data saturation was reached after my seventh interview. For the focus group, 8 volunteers, but only 5 completed the consent form and was available for the interview date and times. Out of 1,200 medical records, 44 were leveraged as triangulation of communication or technology challenges during the telemedicine visits. 5 physicians clearly had objective documentation challenges in their notes. And by triangulating the patient and the physician's perspectives with the medical record documentation, this study provides a rare and credible insight into how telemedicine is experienced and documented in real clinical environments. Applying the technology acceptance model to analyze how communication limitations influence technology adoption, provider trust in telemedicine, and patient satisfaction. Now, data was collected through various processes with ethical and HIPAA compliance consideration remaining central to my North Star to ensure that the study approach respected all participants. To conduct a study and review medical records, there were 2 IRBs. Ooh, the first one was with the hospital and the other was with the university. So the institutional gatekeepers, there were regional quality administrators, department administrators. I had to contact them for permission to conduct a study. I had to sign conflict of interest forms and applications. The information was replicated from the hospital to the school university IRB and describing the purpose of the study. Now, the hospital provided the cohort of the 1,200 patients and primary care physicians. Emails were distributed daily for volunteers leveraging DocuSign. Those that volunteered were provided flyers for their references and consent forms. Questionnaires determined if they met the criteria for the study, and DocuSign was instrumental in keeping track of the consent forms, the flyers, the emails, and the daily reminders. The invites were sent for the one-on-one interviews with the physicians first, and then the focus group was conducted afterwards. And both of these interviews were pretty much conducted through Teams and were transcribed. Then the medical records were reviewed for triangulation. Patients' records were reviewed for the study and did not correspond to the actual participants' medical records. In other words, those that were in the focus group, their charts were not reviewed for the study. Now, I conducted a thematic and content analysis of clinicians' documentation in two phases to verify any communication challenges during telemedicine visits, and after the physician interviews, and then after the focus groups. Member checking was conducted to verify correct transcriptions, and one request, of course, was made for grammatical errors, but nothing was recorded with incorrect interpretations from the participants. So, in analyzing the data collection from the interviews, the Braun and Clark's six-step thematic analysis was leveraged for document analysis. The coding techniques were employed to ensure that key insights were identified and organized. So first I had to familiarize myself with that data, reading through that transcript after the interviews, reviewing the medical records while taking notes of key phrases. In step two, I generated initial codes using the In Vivo 15 coding software, highlighting those key phrases, and then putting those words into little key phrases and highlighting those. But I wanted to keep grounded in the patient's perspective. So that's why I had to really highlight some of those stages in those phrases. And at first, nearly every word seemed code worthy, which was a little bit overwhelming because you have all these codes and all these phrases and words. So once I started highlighting those, I started to group those into codes, the parent codes and the child codes and in vivo. Once I started categorizing those codes, then I can start to organize the documentation. Okay. So after reviewing and refining the themes to better align with the theory and research question, I reduced my 9 themes. I had 9. They all seemed like duplicative. I reduced the 9 to 5 themes, and each theme was clearly defined and concisely named. In the final step, I wrote up the report using strong examples from the data to illustrate each theme and the value participants shared from their experiences. Now, theme 1. So, anchoring onto the theme analysis, the interview questions supported research questions with participants' responses and helped with the development of these themes and these sub-themes. So, theme 1 was the balancing of the convenience of communication and telemedicine. This theme captured patients' responses of their experience with telemedicine, where they constantly emphasized the convenience of avoiding travel, reducing costs, and managing appointments from their home or from work, while also describing communication challenges incurred during their telemedicine visits. There were two sub-themes, sub-theme 1A and 1B, which were the convenience and cost-effective and technological limitations and challenges to effective communication. All participants, P1 through P5, described the transition from in-person to telemedicine as smooth and convenient and cost-effective, as some patients required additional outreach or in-person visits to resolve lingering concerns. Patients reported that disruption such as unstable internet, feeling rushed, and difficulties accessing or logging into telemedicine platforms occasionally interfered with their ability to engage fully with their physicians. Now, these technical issues sometimes cause delays in the start of the visit, interruptions during conversations, or the need to reschedule or convert to a telephone visit. The triangulation of the medical record with the research question and the TAM theory aligns with the perceived ease of use as the provider's documentation confirmed patient unable to connect. The data suggests that communication breakdown and contextual barriers contributing to skepticism towards long-term usefulness, thereby influencing future intent to continue unless improvements are made. Theme 2 was weighing the value of telemedicine and its support research question 2. The second theme was developed from patients weighing the value of telemedicine. Patients described as a valuable option for accessing care, particularly for routine follow-ups, prescription management, or just reviewing test results. There were two sub-themes. There were two sub-themes, 2A and 2B, that reflected a distinct aspect of the telemedicine experience, which included increased patient satisfaction and the perceived appropriateness of future intention. Now, the sub-theme supported patients' experiences navigating telemedicine platforms, their assessments of the benefits of these services, and their willingness to incorporate telemedicine into future healthcare routines. However, participants also highlighted challenges related not only to the technological itself, but to the technology itself, but also to the practical aspect of accessing care through telemedicine. Participants described the conditions under which telemedicine was most suitable and their future intentions to continue. Patients also reported that telemedicine was appropriate for the follow-up test results and straightforward concerns that did not require a physical exam. Participants' reflections on their future use of telemedicine revealed a nuanced perspective shaped by both the benefit and limitation they had experienced. In addition, the triangulation of the medical record documentation of she requested to receive service via telephone supports that the research question and the TAM theory aligns with the behavioral intention to use technology shaped by external variables and subjective norms. Patients' requests may pressure the physicians to adapt. These external demands shape physicians' future intent as patients' preferences may increase the demand despite clinical decisions while acknowledging communication trade-offs. Theme 3 was varied experiences in adapting to communication in telemedicine and was supported by research question 3. Now, physicians describe their varied experiences in adapting their communication practices during that transition. From the interviews, the experience with workflows among them varied, as some had previously used telemedicine in their residencies, while others were still struggling in their second year. There were two sub-themes, 3A and 3B, navigating the uneven transition with nonverbal connection and telemedicine workflow strains. Physicians described the transition with telemedicine as uneasy because some were adapting easily while others were experiencing disruption and difficulty. The physicians also reported communication challenges tied to the absence of nonverbal cues such as facial expressions and body language. Physicians highlighted workflow strains, including inappropriate scheduling of visits, requiring physical exams, time pressures, and the sense of being rushed during back-to-back visits. The triangulation of the medical record documentation supports patient communicating with someone else during the call, supports the research question, and the TAM theory aligned with perceived ease of use. The documentation indicates a lower perception of the utility for effective communication, which may reduce physician satisfaction and long-term adoption. Theme 4 was the PCP's, primary care physicians' perceptions of their realities, because the physicians described both the advantages and the pressures of providing care virtually, highlighting the contrast between perceived convenience of telemedicine and the practical challenges they encountered in their daily workflow. There were two sub-themes, perceived efficiency of telemedicine and challenges with equity and language accessibility. Physicians shared their hidden pressures behind the perceived efficiency of telemedicine services, such as barriers that included communications with specific patient populations. Several participants reported that language differences, particularly with Spanish-speaking patients, created obstacles when interpreter services were delayed or even unavailable during telemedicine visits. Equity in telemedicine emerged as a critical consideration in physician interviews, with participants highlighting how workflow barriers, triaging practices, and language accessibilities, particularly for Spanish-speaking patients, which directly shape the effectiveness and communication of the overall experience. And the triangulation of the medical record of I am unable to visualize your symptoms supports the research question and the TAM theory aligned with future intention of use. The last theme was theme 5, documented challenges with effective communication in telemedicine. So this research question pretty much was used to look at the documentation, to integrate the medical record documentation with the interview data, and it provided a consistent picture of challenges that affected the quality and the flow of virtual encounters. The documentation reflected recurrent issues such as divided patient attention, technical disruptions, and the inherent limitation of telemedicine or telephone visits where physical exams could not be performed. The documentation revealed that encountered frequent distractions, miscommunication, and technical obstacles from both patients and physicians. The note also support written confirmation of the challenges physicians described in the interview. The interview suggests the theory TAM constructs may require reframing work in the post-adoption phase, as telemedicine is no longer considered a new technology in the paradigm shift. The triangulation of the medical record documentation of diagnosis and treatment presumptive based on telephone encounter, patient advised to follow up if symptoms persist, supports the research question, and the TAM theory aligns with the future intention of use. Now, while physicians continue to use telemedicine, their documentation reveals persistent doubts about the perceived usefulness without video, which may temper their long-term commitments. The clinical documentation strongly reinforced the themes and demonstrate how physicians record their experiences and workflow limitations, which enhances the credibility through triangulation. In addition, offering insight into the theoretical framework of TAM that is manifested in their everyday medical practices and possibly shaping their, what happened there? Shaping their experiences. Now, the study has several limitations that may affect the interpretation of the findings, as qualitative studies are typically not generalized, but they are transferable. The first one was the study was designed as qualitative descriptive, which means the purpose was to provide an in-depth exploration of communication dynamics in one healthcare setting rather than measuring outcomes from multiple systems or populations. By narrowing the scope, I was able to gather detailed narratives that highlight not just what challenges exist, but why they occur and how physicians and patients experience them in real time. The smaller sample size is common in qualitative descriptive case studies where the goal is not statistical generalizability, but capturing detailed insight. By focusing on family medicine, the study suggests invaluable insight into a large frontline specialty that often manages diverse patient concerns. However, the findings should be understood within that specialty context. The narrow chart review reduces the ability to draw broader conclusions from documentation trends. At the same time, the records that were reviewed provided important triangulation with physician interviews and patient focus group data, strengthening the overall findings. Together, these limitations mean the study cannot claim to represent all physicians or all specialties, nor can it provide a comprehensive picture of the medical record documentation trends. However, the data collected still offers meaningful insight into how communication in telemedicine is experienced, understood, and documented. Now, recommendations for the leaders, there were four. First was to provide website manner training to help with the rapport building virtually. This could possibly improve the nonverbal communication in telemedicine. The second is to invest in educational material to patients on the expectations of outcomes for virtual visits to ensure consistency for one problem for 10 minutes. This can possibly improve patient satisfaction. Allow physicians to say in how they want to visit, how they want their visits booked. Morning could be for in-person visits, afternoon could be for virtual. And this can possibly improve the physician's perceptions of workflow strains. And lastly, investigate more in language accessibility tools to enhance communication effectiveness with Spanish speaking patients. Now they have earbuds, and recently they have eyeglasses now. And these translators can help with misinterpretations. Recommendations for the practitioners would be since the physicians are the frontline users, we definitely want to establish telemedicine protocols. They should advise patients about one problem for 10 minutes. This can possibly improve the efficiency in telemedicine. Implement patient telemedicine readiness education. Share best practices such as having your questions ready, have your labs completed. This can possibly improve patient and physician satisfaction in telemedicine. Virtual communication techniques like eye contact with video visit tips. They can record themselves to see how they look to their patients. Some physicians were always looking down, during the interviews, or some were looking this way when they were talking on the interview. So just getting that perception of how they look when they communicate online. Use documentation templates to capture visit encounters for that context challenges. Now, pretty much having an objective way to document in the note. Now, this, of course, is not legal advice. It's just advice for quality improvement suggestions, which can possibly improve the effectiveness of telemedicine. And I moved too fast here. Number 5, evaluate the modality fit by visit types to guide the appropriate scheduling. So advise the nurses on how to book on their behalf, which can possibly improve the physician's perception of effectiveness on telemedicine. No physical exam should be scheduled by phone. And the last one is engage in feedback loops for continuous improvement because voices matter. Speak up on what's working well and what's not working well. This can possibly improve both patient and physicians' perceptions of future intent on telemedicine services. So 4 recommendations for future research would be definitely try a mixed method design, focusing specifically on video consultations with internal medicine physicians. Since telephone modalities were a little bit more limited, the current sample only included family medicine. So another one would be a large scale quantitative study with a broader population with primary care could probably strengthen the generalizability and the statistical power. A multiple case study design could offer a comparative lens across various healthcare organizations, and this approach can incorporate snowballing sampling methods to recruit patients from diverse geographic locations, possibly either different age groups too, maybe 30 to 59 or 60 to 85 years of age. These specifications would allow researchers to examine how experiences with telemedicine has evolved in the post-COVID landscape, especially the physician's time management skills. So in conclusion, 5 themes, 4 sub-themes were developed from the study. Through 3 data collection approaches and thematic analysis, this study offered valuable insight into the complex factors behind the communication challenges patients and primary care physicians encountered. Key findings from interviews, focus group, and medical record documentation demonstrated experiences and perceptions of communication between the two during their telemedicine interactions. Clinical documentation substantiated these themes, reinforcing the credibility of the study findings. The documentation reinforces providers' verbal reflections, highlighting concerns around communication quality, diagnostic limitation, and patient engagement. This study contributes meaningfully to the growing body of knowledge on telemedicine by addressing a critical and underexplored issue, the effectiveness of communication between patients and primary care physicians in telemedicine interaction, particularly in the post-pandemic healthcare landscape. While existing literature has largely focused on telemedicine, technical implementation, access benefits, and general patient satisfaction, this study uniquely explores the relational and communicative dimensions of virtual care from the perspectives of both patients and the providers. and triangulates these findings with objective medical record documentation, not necessarily proving the challenges, but describing their experiences in a post-pandemic landscape. So why should you care? Patients are demanding more accessible care, yet their engagement and understanding may suffer in the process. Physicians are being asked to deliver high quality care in low context environments with limited tools and overcome communication gaps. Healthcare systems are investing in telehealth infrastructures without always considering its communication risks or training needs. And documentation reflects a hidden narrative, one where disclaimers, fragmented visits, and missed visual cues are silently impacting the clinical record and legal risk. Future healthcare delivery is hybrid by design. Understanding how to enhance virtual communication now will shape long-term patient safety, satisfaction, and outcome. Now, anchoring onto the quintuple aim to create a healthcare system that is not only efficient and cost effective, but also patient centric, equitable, and supportive of healthcare providers. In short, this study bridges the gap between technology and humanity in healthcare. It is also a call to action for scholar leaders, practitioners, clinicians, and administrators to not only embrace innovation, but to ensure it preserves the heart of care, which is meaningful, clear, and trust-filled communication between patients and providers. So my next steps, my doctoral research can evolve into a real-world framework, as you saw. My next goals are to present the results to the organization studied and share two results with two different journals in healthcare management. Currently, I'm writing my doctoral journal with the intentions on writing an ebook for patients and providers using telemedicine. And this concludes my presentation. Thank you all for your attention.
Okay, I want you to take a nice deep breath.
Okay.
Okay, ready? Deep breath. You got this. All right. Thank you so much. Committee members, can you please come back on camera and back on mic? And I respectfully ask the rest of the audience to leave so that we can ask questions. And I'll wait till everybody leaves.
Yeah, well done. I'll log off, but congratulations and compliments to your committee for all their hard work. It was very well done. Thank you.
Thank you.
Excellent.
Okay.
Woo,
Hold
that
on,
was
we
a
still
mouthful.
have two people.
Yeah.
Hold on. And one more who is RN, whoever that is.
I don't know what that is.
I think that's some kind of software that's recording the
That's just
meeting.
notes.
Oh, hold on, just
You
put
can
my,
just delete that. Yeah, you can
Yeah,
just
I just
delete
put-
that, Karen.
what's that?
You can just delete it. I see that all the time. People just delete it. I don't know what it is.
Yeah.
Nobody knows.
Yeah, it's
And,
the thing. I just want to make sure because we had 21 people and I just want to make sure that we have no one else
That's not a
on
person.
at this point.
Yes.
Yeah, because I think that Malcolm was on and he's tomorrow night from me. And I think 4 more people who are in getting ready. So anyway, all right, Karish.
yes.
Okay, you want to have to like wiggle it out or anything?
Ooh.
Okay. All right, take a drink of
Okay.
water. Take your drink of water.
I don't have any in here.
That was your one job. You're supposed to get water and turn your phone off. Okay, but anyway, all right, so let's open it up to committee members. I'll be the last one.
Who wants
my
to go
God.
first, Liz, me or you?
Okay, why don't you go first, Gorgana? And then that way we'll do Liz and then I'll go.
Okay, so Karish, first of all, I just wanted to say that your PowerPoint presentation was visually appealing and I loved it. And as you were going through, each of the slides, I could tell that you really know what you're talking about. So it was not just like, okay, this is the slide, this is what I'm, saying, whatever, but it's really great job preparing for this presentation. So my first question, I have 3 questions for you. My first question is, just generally sharing your experiences about the high and low points from your dissertation experience. It could be anything from the beginning to the end, whatever you choose to talk about.
And it has to be 3.
Okay.
You
It
want
doesn't
3?
matter. 1, 2, 3.
Oh, you can do one because I know you're getting closer to the 6 o'clock hour, so you can do one.
Okay.
Okay.
The one I would say, one of my experience, if I had to do it over again, would be that, okay, would be the problem statement because I remember that was a challenge for me because knowing what I know now, a topic and a problem statement are 2 totally different things. Sorry, too
Do you know
late.
who this is?
Yes, yeah, I
Okay, is
know
this
who
a,
that is.
a friend of yours?
Yep.
You want to admit her and then tell her to leave? Well,
If
she,
she
because
comes
she's,
back on. Yeah, if she
okay,
comes back in, I'll do it.
okay.
So just understanding the topic. The topic is something totally different from a problem statement. And that was just my hang up from the beginning. If I had to do it all over again, I would really go back into the literature to find out what the problem was instead of searching on Google for a topic.
Okay. You know what? I don't want to waste too much time, but I tried to figure out which slide it was, but it was the slide where we had recommendations for future research and you had those different groups. So what was the idea behind, recommending future research for, having participants, different age groups? Briefly, you don't have to go into too much detail, but what was the reason behind that recommendation?
Oh, because the participants that I had, they all were within one specific age range, roughly 30s, 40s. So it would be nice to hear the story from people of different ages. Maybe they've encountered something different than the younger population. I did have one that was really, really young, and she kept saying, I don't have any problems. I don't have any problems. But the ones that were a little bit older, they did have problems.
Yeah, well, that's a good insight because I and you talked, I'm sure you have talked with your other committee members, but how I was trying to schedule a, dermatologist appointment. You know how those take 6 months to schedule
Yep.
them, and it was supposed to be a telemedicine, and we couldn't connect for 15 minutes, and I was panicking and calling, and it was very frustrating for me
Yeah.
as a not patient, but the mother of the patient, because I know, okay, now we missed the boat, so to speak, but it was not my fault. It was the office, the whole, setup and,
Mm-hmm.
issues with technology, etc. And I was panicking. I was so upset because I thought, well, maybe we have to wait another 6 months or whatever, because you don't get those appointments very often. And
Mm-hmm.
so I can, can see how frustrating that can be. So thank you for sharing that. One final question that I have for you is, what do you see as the main contribution of your research? I know there is some research on the topic, but at the same time, telemedicine is not really, it has not been here for 20 years or whatever. So what do you think your contributions for your research are? And I know you're working on publishing your study, so that's a great news,
Yeah,
so to speak.
yeah. Yeah, researchers want to know what is it like post-pandemic? What is it like? So I think my research is really, really added to that body of knowledge by sharing those real world examples and experiences.
Good. Well, you know what? I honestly don't have any other questions because, I and you with the whole committee have been working so closely on, getting you to the proposal level and approval,
Mm.
etc., and very closely with the data analysis. So, I don't have any other questions, but thank you so much. And again, it was such a pleasure to see you present today. You did great. It's wonderful. We'll miss you for sure.
Oh, thank
Karish, you
you.
can take off the recording. I thought the recording is off, but it's still
Oh,
on.
oh boy. Stop recording.